Hello and welcome to our Tree Academy online webinar with Dr. Torsten Kamm from Baden-Baden. The topic today is a very interesting topic. We have techniques for immediate loading to achieve superior aesthetic results. And Dr. Kamm is going to show us a lot of nice cases, and I'm very happy to do this webinar today with Dr. Kamm from Baden-Baden. But before I give the word to Dr. Kamm, I would like to shortly explain in our philosophy the performance concept. The performance concept of the tree implant system is basically 4 gold standards, and I want to point out 1 or 2 gold standards which are important for achieving primer stability in techniques for immediate loading. So the immediate loading needs a good primer stability, and there's 2 points basically very important, and this is in our system the bone adapt. The bone adapt is describing the implant design. So the tree dental implant has a conical tapered design, as you can see here. And we have more or less 3 different steps of thread designs. So in the lower part, the black area here in the apex area is with a 45 degrees angulation of the thread, very aggressive. So you can have a self-cutting area here, and this gives you a good high primer stability. And also in the middle part, we have a 60 degrees angulation of this triangle, as you can see here, which gives you also in the spongiosal part of the bone a nice primer stability, which is really important in the immediate placement technique. And then on the top part, we have the square thread pattern here, so it's slightly flattened out, so the crystal area is not compressed too much, the bone is not compressed too much, which is important too, to have the blood circulation. And then also what is important in the tree dental implant system, we have a triple leaded thread design. So that means from the apex, which you see here on the right side, we have 3 independent threads circulating the implant body, which you see here, the red, the green, and the blue. For example, the green thread design is circulating and comes up here and here and here. So that means we get a feeding rate of our implants of 1.8 millimeter, which leads to that we have in 360 degrees turning the implant, we go 1.8 millimeter down, which is also very important for reaching a high primer stability. And we are really proud to have this scientific white paper, which we just announced at the EAO in Paris 1 month ago, and it shows that our due to our thread design of our tapered implant, we achieve a very high torque during drilling the implant in, and reach a very high primer stability comparing to other companies in the market. And then there is the second very important factor of reaching primer stability or stability in all is the surface. And this is another study which is made, which we present in the EAO in Paris shortly before. And that shows that our surface has the same roughness than the SLA surface from Straumann, for example. And that means that we have these 2 factors which are very important for immediate loading and also immediate placement to reach the highest primer stability. And this is also the last slide from my side, and I'm very happy to give the word now to Dr. Torsten Kamm from Baden-Baden, which you can see here on this slide. He has a very beautiful praxis in the middle of South Germany. And yes, Torsten Kamm, I would like to give you the word now. and I have to change the presentation modus to you. 1 second. Hello, can you hear us?
I hear you.
Okay, hello, Dr. Kamm, hello.
So one second.
I change it. Second, yeah, should go now.
Okay, can you see me?
Yes, I think we can all see you. Before you start, one thing, the rule for the webinars is all participants can ask questions during the presentation of Dr. Kamm. It would be nice if you just type your questions into your question part, which you see in your toolbar on the right side. So you can type in questions which we're going to answer after the presentation of Dr. Kamm. And so after the presentation of Dr. Kamm, we have time to answer questions. And so during the presentation, please just type them in this question folder or in the chat folder. Okay.
So let me start it. Okay. So I start now the presentation. Can you all see it?
Yes, we can see it nice and clearly. Pink Aesthetics implantation.
So our topic today is pink aesthetics in the implantations in aesthetic zone. We want to discuss today when to put an immediate implant in the anterior region, when we can make immediate loading, and when we have to make a second stage surgery and it's not possible to go in with immediate loading. So first, one short introduction to myself. I'm from Baden-Baden. This is a nice, very famous city in Germany. It's southeast of Germany. You see it here on the map. This is a red point. You can see there's Baden-Baden in Germany. Come a little bit closer. This is a very famous city, Baden-Baden. It is near of the Black Forest in Germany. And now you can see my practice with a red point on the side. Some short impressions from practice. We are 12 years in Baden-Baden now. We have five colleagues, all with different specializations. And we have some research with some famous universities in Germany, like Freiburg, Aachen, and Mainz, and so on. So let's start. Aesthetic roots in the anterior region. Before we start, we have to discuss what did it change if you have a teeth in the anterior region or you have an implant in the anterior region. It is very important for us to see the difference. I go with a some problem with the mouse. Why I can't see the mouse? Can you see the mouse? I didn't see it.
Yes, just now, yeah, I can see it. We can see your mouse, yeah.
I can see it. No problem. Yep. On the picture, you see a different. One side, on the left side, you see the soft and the hard tissue if you have a normal teeth, and on the left side, you see the implant tissue. And the main topic point and the different point is that you have no blood between the teeth and the bone, and between the teeth and the soft tissue. And also you have no fibers, sharp fibers going directly into the implant. If you have the teeth, you're getting fibers going directly to the roots. It's different from the implant. And let's make us some special difficulties if you make an implantation. So we have not the same blood. If you have make an implantation, you have not the stability of the soft tissue because you have no fibers going inside the crowns and the implant surface. So we have to react a little bit different from the normal teeth. But first we have to discuss when we can make an extraction. We have to state with an immediate implantation. You see it on the topic. Extraction, implantation with or without GBR. On the next slide you see the technique like Daniel Buser does it. You make an extraction, leaving 6-8 weeks, then make an implantation, waiting another 8 weeks, and then you get a crown on it. And sometimes if you have no bone or big infections inside the bone, it's not possible. You make an extraction, waiting 3 up to 6 months, then you're making a augmentation, and then you can make an implantation. So, but we want to discuss about how to make immediate implantation and in the most cases, immediate loading. Because if you have cases, we have enough bone, we have enough soft tissue, you will, in all cases, you make immediate implantation with immediate loading, you're getting the best results. So if it is possible, we try to make an immediate implantation with immediate loading. So we have to discuss when we can make it. We have 3 types of socket classification. Type 1, you have an intact bone and an intact soft tissue. You see it on the top. In the middle, you see class 2. We have an intact soft tissue, but we lost the buccal bone. And you see type 3, we lost soft and hard tissue. If you have the case 1, it's no problem in most cases. You make an immediate implantation and immediate loading. Only in your case you have a very big infection in the apical zone, then it's not possible. But in most cases, it's no problem to make an immediate implantation with immediate loading. If we have case 2, it's much more difficult. Then in most times, you can do immediate implantation, but not in the most times you can immediate loading. So we have to change our concept a little bit. If you have case 2, make an immediate implantation in most cases, but not immediate loading. And if you have type 3, it is not, in most cases, not possible to make immediate implantation and immediate loading. This is the case we make techniques like, I show you later, like socket seal, ridge preservation techniques, that we extract the teeth, put some bone or some tissue inside, and then we make cover it with a CTG or with some membranes, and after 3 or 4 months, we can make an implantation. So let's a little bit look in the history. We started with immediate implantation and immediate loading in the 18th. You see some picture from Garber, Salama, and Salama brothers. You see we make a lot of mistakes when we start with immediate implantation, because we all thought that we have to put the implants in the same direction like the bone is. But today it changed a little bit. We make more angulated implantation because we want not to have the most bone, because we have now new implant types like the tree implants, so we have much more primer stability. So it's possible today to change the angle of the implant, and this is the reason why we're using small implants. On this picture you see the next mistake we make in the past, using big implants. Implants have the same diameter like the socket has. This was a very, very big mistake in the past. Today we make smaller implants and make an augmentation, because we know in most times we get a remodeling of the bone, and so if you're using too big implants, you will destroy in most times the buccal bone, and is not allowed to touch the buccal bone, because if you touch and destroy the buccal bone, you lose the most of the buccal bone, and then you're getting a very, very bad aesthetic result. So we have to use small implants, put it a little bit more on the palatal side. So it's very easy for us to put a small implant with the new design, with a tapered implant like the tree implant, with a high primary stability, and then we can using immediate loading, or can just make immediate implantation. This is all the cases you see in my slides are made with implant systems, with tapered implant systems, because if you make immediate loading and immediate implantation, you need a very, very high primary stability. If you're using a standard implant like a Straumann or Astra or something, some other systems, most of these techniques you see in the next slides are not possible, because the standard implant and straight implant have not enough high primary stability. So it's not possible to getting a primary stability above 35 Newton centimeters, and you need 35 up to 40 up to 50 Newton centimeters to make immediate loading. So you see, this is the past. We're starting with only a 3D X-ray, but in the future we're changing to 3D, and this is another important thing. If you make immediate implantation and immediate loading, it is necessary to get a 3D X-ray. We get so much more information about 3D X-ray. It is very important to see some of the X-ray. There's some infections to see how high, how big is a bone. You see different angles and different axes. So it's very important to have all this information, especially in the anterior region. If you make an implantation in the anterior region, in the upper jaw, it is necessary to know how big is the nerve channel and how is the relationship between the nerve channel and the rest of the bone. So it is all this information very necessary to plan it and make a backward planning how to put an implant. To see here, it's a case. This case is 6 years old. This is a young girl, have an accident, and she comes to the dentist. She makes 4 root channel treatments. All treatments failed. And to see the big infections and to see the loss of the bone, and also to see the angle of the teeth. And this, I make this examples because in the past you see the planning on the left side. This is the old planning. 10 or 20 years ago, all dentists put the implant in this direction. You see the angle of the teeth is different from the angle of the ideal implant axis if you put the implant totally in the bone. This is the past. It is very good to getting very high stability, but it's very difficult to cover these implants with crowns. In the last 5 years, we changed this direction. You see, we want to have the same angle like the teeth has before. Also, we want to get a little bit more on the palatal side, but to get a little bit more bone. But the angle is mostly the same like the teeth has before. This is changing now because it's very easier to make a crown on it and to get a perfect shape and a perfect emergence profile if you have the same axis like the teeth has before. So this is new because the stability of the soft tissue after 5-10 years is much more stability if you're getting different axes from the past and the same axis like the teeth as before. And also you see the big nerve, you see it's on the left side. This is very important. If you make on the left side, you see if you make a big implant diameter, it is not possible to put the implant on the palatal side and going not into the nerve. So it's very, very important for us to have a small implant diameters, stability, primary stability, and a very stability implant. Because the tree implant is a titanium grade 5 implant. It's a very, very hard material. It's much harder than like a Starman or like an Astra. It's only grade 4 titanium. So you're getting a much more improve of the stability of the implant, and so it's much easier to get a smaller diameter and getting the same stability of the connection between the crown and the implant. So you see next pictures. This is very important for the planning. If you're going to the front, this is the case we're losing 4 teeth. It's very important to put only 2 or 4 implants inside. And today we only put 2 implants in this region, because it's much more easier to getting a more stability soft tissue, and it's much more easier to getting a long-term aesthetic result, because you have it's much more easier if you have a one implant and then a bridge to getting a much more higher papilla. It is not very easy to getting a high papilla between 2 implants. And in our aesthetic rules, it's not allowed to put 2 implants in the anterior region. You can put an implant on the 1.1 and a 1.2 position, but it's not allowed to get an implant on the 1.1 and the 1.2. Also the small canine and the big canine. Yeah, it's not possible. It's also the same if you're getting 1.3 and 1.2. It's implant in this position. Never do this, because it's not possible to getting a very good aesthetic result, because if you see the structure of the upper jaw, you see how deep the implants come together. It is not possible to getting the ideal range between two implants in this region. So it's not possible to getting, after this I show you some slides about the rules. If you put implants in the frontier region, it is not possible if you're getting two implants near together to getting a good aesthetic result. So in all these cases, put only two implants. You can do it on the small canine region. You can do front canines, or you can also do it on the big front teeth. It's no problem, but only two, yeah? Not four. And then you're getting results. This is, you see here, this is implant on the frontier region, and you see how big is the bone on the buccal side. And this is these builds very important for us. If you're getting a big buccal bone, then you're getting a very big stability of the soft tissue. After 10 years, 20 years, and you're getting no recession. And this is changing. It's difficult from the past. If you're getting a too big implant in this region, it's not possible to get a stability soft tissue for 10 or 20 years. But if you see it on the slides, if you have a very, very big buccal bone, you see it's up to 3 millimeters, and it's no problem to getting a very stability situation for 10 or 20 years. So small diameters, a little bit deeper, and it's important to get a big buccal bone on the cervical part of the implant, not on the apical side. It's not important. On the apical side, you can go outside the bone. This is because if you're changing the axis, it's no problem to get a little bit outside the bone. It's not important. You have the same if you have normal teeth. You have so many fenestrations of the teeth on the buccal side, but it have no outcome for the aesthetic results. But you need a big buccal bone on the top. It's very important. So next slide. There's one of the cases. You see the case you've seen before in the X-ray. You see it's a very stable situation. You see it was a root channel treatment. It's a failure. You see some defects of the soft tissue. And this is, but we have very good stability soft tissue situations, and we have very good situations of the hard tissue situation. So very difficult is how to remove the teeth. We have, I show you in the next slides some different techniques how to remove the teeth. Very important with all techniques is not to touch the buccal bone. Because if you touch with the drills or with something other things, the buccal bone, you destroy the blood cells and the blood reaction of the buccal bone, and then you will lose much more bone. So it's very, very important to, if you extract the teeth, don't destroy the soft tissue and don't destroy the hard tissue. Because if you're getting much of destroying of the hard or soft tissue, your aesthetic outcome will be much more worse. You see here some techniques. You can separate the teeth and go a little back. You see in the sagittal direction, you can separate the teeth and put all pieces outside, and after this you see there's no big destroying of the soft tissue. If you're seeing the last picture slide on the right side, you're seeing, if you're looking from outside, you're seeing no touching, no blooding, no destroying, and also if you look inside the socket, you see no blood inside, and that is important. If you have a good cleaning and if you have a very atraumatic extraction, you're getting not much blood inside. If you have so much blood inside, you have much more destroying the soft or hard tissue. And it's not very good for the aesthetic results after 1 or 2 weeks. This is a very difficult case. You see here we are making another incision on the buccal side, because you see if you're looking inside, we have a very good bone situation at the top of the socket, but on the apical side you have no bone. But this is new in the, for us. We're changing this for the last 5-6 years. If you have good situation on the top, this is no problem if you have no bone on the apical side. So in this case, we can do immediate implantation and with immediate loading, because you see my classification of the socket types. We have type 1, 2, and 3, and this is type 1, because these types describes only the bone on the top of the socket. Yeah, if you have a hole in the apical side, it doesn't matter. Then we make a drilling. You see, we have a very good bone situation at the top, and we have no bone at the apical side. And also, you see the axis. We come with the apical part of the implantation. We come outside of the bone, but it's no problem. This is a very easy case to cover it, and we put some human bone on it, cover it with a membrane, and it's a very easy case because we have a 3-side socket, and we know a 3-side socket from 3 sides is very easy for the human body, getting enough bone from all sides, enough blood cells from all sides, so it's no problem to cover it to get a very good long-term situation. But you see the X-ray before, you see how big was the bone after 3 years of implantation. It's the same case. So then you see this is the old design. You see the old design of the tree implant, because the package has changed now, but this case is 4 years old. Then you put the implant. You see a small diameter. It's only a 3.3 millimeter implant. I told you before we're using a much more smaller implant. In the front region are using 3.3 or 3.5 or 3.7 diameters implants, not bigger. If you have the canine region, sometimes 4.0, but most times 3.7 or 3.3. And you see this, to cover this implant is no problem. Then you see in the middle of the picture, we got a CTG grafting from the peritoneal side. And now we come to the aesthetic rules. As we started before. If we have want to make an implantation in the anterior region, it's very important to see how we must put on the implants inside. You have several studios from Tano, you see Kadaropoli and so many other famous guys. We know so much in the future how to put an implant inside the socket. But there's one new thing we have to discuss before. All these research, you see now this is a study from Dennis Tano, are done with different implant types. You see now the study from Dennis Tano, this research is done with a triple I implant. And the triple I implant reacting totally different like a tree implant, because it's a straight implant. You have this is an old design of the triple I implant. You have a hex, outside hex implant, and you have much more instability of the connection. So you have much more moving from the abutment and the implant. So it's we have to change a little bit more, because if you're using one-piece implants, some manufacturers make one-piece, especially the ceramic manufacturers. It is totally different, because on this study it shows us if we have an implant range, one implant to another implant from 4 millimeters is perfect, not 3. We all want 3 millimeters range from one implant to another implant, but the best point is not 3, it's 4 millimeters. So then you see in the front, it's not very easy to get a range from one to another implant from 3 or 4 millimeters. It's a very huge gap. So this is a reason for our practice to using small diameters, because if you're using small diameters, it is much easier to getting 3 or 4 millimeters between each implants. But if you're using 4.1 or 4.7 implants, it's not possible, and you have only 1 or 2 millimeters of range. So the other thing is, if you have using one-piece implants and you have only 1 or 2 millimeters, then you have the same situation like a normal teeth. In my practice, we have so many one-piece implants, and if I have only a gap from 2 millimeters between two one-piece implants, it is no problem. I'm losing no bone. But if I have normal implants like not one piece, like the tree, like Zimmer, like Straumann, then I have to getting a bigger gap, like 3 or 4 millimeters, because one-piece implants react totally different from two-piece implants. So I told you that before, because we have to change our outcome totally, because all the research in the past from famous guys like Tano, as you see on the pictures, are with one implant systems. And these guys told us these rules for every implants. And that's not true. If you have more modern implants, like a Noble Active, like the tree you see pictures before, it's different. So tapered implants have totally different connections between the abutment and the implant. And so we have to, in the future, we have to make more and more research if we have the same rules. I don't believe if we have the same rules, because in my practice, I have different outcomes with different implant designs. So we have to know all these rules, but we don't know if all these rules are necessary for a tree implant. So the next rule is how to deep get an implant. How is there a gap between the implant and the teeth, and how many bone we will lose in the vertical side. So it's another study from Dennis Tano, and they show us if we're going too deep, the gap is too small between a triple eye and the teeth, we're losing much more bone in the vertical direction. So this is always the same. If you have one-piece implantat, I have so many cases, I've never seen this effect. If I'm having a triple eye, Dennis Tano show us he has this effect. So with all difference, we have to discuss. There's another thing, if you're using a triple eye implant, getting better performance if you make a platform switching. In my opinion, if you're using a tree implant, we have always a platform switching, because this is a totally different implant design, and we have a platform switching built inside the design of the implant. So we're getting the same results like on the study. In most cases, we're getting less bone loss, because our little connection from the abutment and the implant going much farther away from the bone contact. And this is the reason the most famous speakers said that you're getting not so much losing of bone. It's the same if you're getting on this time a one-piece implant, you have no bone loss, because you don't need a platform switch. So on the next slide is shows how deep must the implant going inside the bone. And this is very interesting, because there's so many different studies. If you have a rough surface and you're going deeper, it's no problem with the implant. But if you have a surface, a machinite surface, not a rough, a machinite surface, it is not allowed to go much more deeper. Because you see it on the right side, it's a Straumann implant. If you're going, you see the rough, the dark gray color shows the rough surface, and the brighter gray color shows the machinite surface. And you see it from A to F. If you go see it at E and point F on the right side, you see you're losing much more bone. So it's not allowed with implant, with a machinite surface, to go much more deeper under the bone, because after this you will losing the buccal bone. And this make if you're going too deep with a wrong implant design, you know the old design of this triple eye with the first three loops of the implant are machinite. It's a very bad design. This is not very good for immediate loading and immediate implantation, because we're losing much more bone. It's not easy to getting a stable bone clot on the machinite surface. So if you want to make immediate loading, you need a tapered implantat, and you need a rough surface just to the right, to the top of the implant. It is not allowed to using implants with a bigger part of machinite surface. because all of the studies. You see, if you're using a machined surface and you're going deeper with the implant, you're losing the bone. Okay. So on the next surface, it's a very new study. It is very interesting. How react the buccal bone if you're making a dual zone augmentation? I show you in some slides after this what is dual zone. Dual zone means we're making our augmentation with human bone. You can make it from human bone from the case. If you have a drilling, put the drilling bone outside without using cooling. And my protocol is to drill inside the bone with only 40 up to 50 rounds per minute and using no cooling. So it's no problem. It's like a protocol from Arniture. And so I'm getting many bone outside the drilling hole. So I'm using this bone for the augmentation, and then I use some human bone like Purus or like Cortico from Botis. It's always the same. But if you make this dual zone augmentation, means you make an augmentation inside the socket, inside the hard tissue, and you make an augmentation in the soft tissue part. And that is totally different, like using BOS or some material like BOS. Because BOS you can also put inside the hard tissue. And this is the reason the human bone, like Purus or from Rotis, react totally different from material like BOS. Because if you make this dual zone technique augmentation in the hard and soft tissue, the human bone will stabilize the soft tissue. That is very new. So we can have a more stability in the soft tissue, and the human augmentation inside the soft tissue, after 3 or 4 months, it will be gone. You're losing it. It will be remodeling in normal soft tissue, and you're getting a little bit more fibers inside this area. And this is the reason why we get very high stability of the soft tissue. So this is very new, and it's a very good study from Chu. It comes from 2012. It's very new. As you see, if you make looking at the pictures at the left side, you see just to put in immediate implantation. The pictures links is immediate implantation, immediate loading. And on the right side, you see a dual zone augmentation and immediate loading. And if you look at the statistics down, you see the loss of the bone of all sides. And if you look at the black color, you see this is a case 4. You see you have case 3 and case 4. You have no much bone loss. That's the reason for us, our new technique since the last 3 years, to make a dual zone augmentation with cover it with a screw or cover it with a crown. Cover it with a crown, with a provisional crown. It's for me the best result, but it's not possible in all cases. This is the reason I told you before. If you can make immediate implantation with immediate loading, you're getting best results ever. You see it some cases from my practice. I show this slide to show you how deep to put an implant and what is the angle and what is the right position of the implant. On the left slide, you see we have a big gap between the implant and the buccal bone. It's very important. Never touch the buccal bone. This is one of the keynotes you have to go after this lecture. Never touch the buccal bone. Making a small implant, you see you have a big gap between the bone and the implant. Put the implant, if you have a rough surface, at least you see it with this tri implant. Put it 1 millimeter between the bone height of the approximal side. But if you have a very big loss of the buccal bone and soft tissue, then you have to go a little bit deeper. But in most cases, if you have a case like this, normal socket type 1, normal bone, normal soft tissue situation, just 1 millimeter below the proximal bone. So it's very important to measure the bone before, and then you can put the implant and go 1 millimeter deeper. The other thing is you see the angel on the left side. You have to make this line is very important to always, if you come out with your drills, you have to come out on the palatal side of the front incisors. It's very important. Then you're getting the perfect angle of the implant, the perfect position on the palatal side, but you have to go not too much to the palatal side. This is the reason why we need a 3D X-ray for all this position. Have you enough bone? Can we do this angle? Have you make augmentation on the buccal side or no augmentation? This is the reason for all these cases you need a 3D X-ray before. So this is another case. You see, this is in other systems, but I chose this because it's easier with some systems to going how deep you can make the implant. You see the mark on the left side of the implant, and this mark will be 3 millimeters. And so I measured before 2 millimeters below the implant, below the soft tissue begins the bone, and so it's very easy to handle the implant. How deep I have to screw in my implant. Also, you see the position. You have the right position. You have the right angle. It's very important in this area. Only if you're getting 1 millimeter on the left or right side, too much to the palatal side, too much to the buccal side, the right angle, then you're losing soft tissue. This is very important. This kind of implant, immediate implantation, immediate loading, is not very easy. It's not all these cases are expert cases, not a beginner cases. It's very important because if you getting the wrong position, wrong angle, you're losing soft and hard tissue. So that is very important. Summary from me: the distance between two implants, the perfect distance is 3 up to 4 millimeters. The distance between the tooth and the implant, you know it, 2.5 up to 4 millimeters. And if you look at the studies from Tano, he showed, and the most people know, 1.5 millimeters. That is not wrong, but 1.5 is the minimum. The optimal in his status from Tano and from Connective are not 1.5. The optimal is 2.5 up to 3 millimeters. It's like the same range from one implant to another implant. If you have 3 millimeters on both sides of the implant, it's optimal. And this is the reason for me, I told you before, small implants, because this is very easy with a 3.3 millimeter on the most cases to get 3 millimeters between the implant and the tooth. And then you're getting better results and the better outcome of the soft tissue after 5 or 10 years. Then another important thing is the distance from the contact point and the crestal bone. In my practice, if I put make the second stage surgery, if I make or after implantation, I measure the distance between the soft tissue and the bone, because it's very important for the laboratory after you're making the final crowns that your contact point have to be between 3 up to 4 millimeters above the bone, not above the soft tissue, above the bone. And the laboratory not where is the bone. Say if you get a model, they only see how high is the soft tissue. So it's very easy for the most laboratory. If you measure the thickness of the soft tissue, it's very easy for the laboratory to make the contact point between the teeth or the implant crowns on the right height. In most cases, the contact point is 6 up to 7 millimeters above the bone. That's much too much, because it's another rule. If you have a contact point like a normal teeth you have 6 up to 8 millimeters above the bone, then you will lose your soft tissue in this area, and you're getting no papillas. Yet this reason is why, you know, the first slide from my pictures, we have no fibers going inside the root. If you have a normal teeth, you have fibers going inside the root and can stabilize the papilla. If you have a normal implant, we have no fibers. This is the reason that our contact point have a little go 2 up to 3 millimeters down to the soft tissue, like in normal cases. So this is one slide. I make only one slide as I find it on the internet, and some cases I have seen before in my practice. All these guys make the failures I told you before. The implants have a wrong. Let's start to the left side. On the left side, you see two implants, and the implant's much too big. The diameter is much too big. And you see if you see the X-ray down, you have no buccal bone. And this case looks in the first 1 or 2 years very nice. But after 3 or 4 or 5 years, you see the recession on the buccal side. This is a big discussion in the USA, because in the USA they make so many immediate implantation. And for 10 years or 20 years ago, we know nothing about how is the diameter of the implant, how is the right angel position, and we make so many mistakes and failures. And these are on the left side are the results. If you're getting two big implants, wrong position. So see in the middle case, you see the wrong position. The implant is much too much on the buccal side. It's the same result. You're getting a big recession on the buccal side, and all this implants in this case you've seen must have to be extract, and you make a big augmentation, and after this you can make a new implantation. So it's very hard to correcting these cases, because in all these cases you see you have to remove the implants. So it's very hard for the patient. It's very expensive, and you have to make a lot of surgery. So next chapter is immediate loading, and it's also for us it's very important why immediate loading is possible. So we have so many different lectures and speakers make research, and we know if we have a gap between the implant and the bone in the socket, it is no problem. If we have a gap, like you see in the famous study from Botticelli, if a gap from 1.5 millimeters is no problem. We know from some other guys, if we have 2 millimeters, it's the same, it's no problem. In my practice, if I have 1 millimeter or less, I make no augmentation, because it's not possible. I make, in all these cases, do a soft tissue augmentation, because I told you about the advantage before. But I make no hard tissue augmentation, because the gap is very small. But if I have a gap from 1.5 up to 2 millimeters or much more, in all cases I make augmentation with human bone materials. So there's one case with we have to try immediate loading. It's a very tough case, because it's very high risk case, because we have a gummy smile in this case. We have the canine position, because canine have in most cases go a little bit outside of the from this place, a little bit outside of the teeth position. And the other thing is, in this case, it's not possible to make another thing, because you see the canine on the point position 2, 3. We have to extract it, because we have a fracture, and we have 2 implants with a bridge, and it's not possible to remove the bridge without destroying the bridge. So we discussed this case with a patient, and we are both saying, okay, in this case we can do an immediate implantation with immediate loading. First, we have to make always the same treatment. We make a 3D examination. You see the buccal bone is not very thick. You see the position of the angel of the teeth. If you make an implantation, you have to go outside and apical side. It's very hard to handle this case. And we have a very thin buccal bone. There you see the case. In the middle picture, you see how we, in most times, if we have to extract teeth in the anterior region, we're using the systems from the company called SEPS. It's called the Benning system. It's not so easy to handle this system, but if you are getting a little bit training with this system, it's the best system ever. Because if you're using this system and you extract with this system the teeth, you're getting no damage of the bone and the soft tissue. It's like you open a bottle. It's very easy, and it's the best for the bone and best for immediate implantation and immediate loading. On the left side, you see the socket after extraction. You see little blood, but not much. You know, no destroying of the soft tissue, no destroying of the hard tissue, and you see how is the shape of the bone. It's the buccal side. It's thin bone, and you see the curve of the buccal bone. So it's a very tough case. It's not easy to handle this. So it's important to make a very atraumatic extraction. Then you see it puts the implant inside. This is 3.7 millimeter diameter implant. You see it's a small implant for this big teeth. And you see if you have a canine position, the canine has a very big root, so it's not necessary to go to the much to the palatal side, to go much more in the middle of the socket, a little bit more to the palatal side, but like in the central position. And then you see you have a very big gap on all sides of the implant. And then it's important to get a very good implant design, so that you're getting very high primary stability in the apical side of the implantation. This is only if you have a tapered implantat, if you have an implantat with a very aggressive loops, like the tree, is a very if you have a triple loop like tree implantat, because this is getting much more pressure inside the bone. If you have your triple loop, if you have only one loop, not a triple loop design, it's not possible to get a pressure inside the bone, because the loop's going also inside the same position of the bone. It's not possible to getting a very high pressure inside. Then you see on the right pictures, you see the CTG augmentation. In most cases, in the past, we make a CTG. Now we change a little bit, because we make in most cases a combination of CTG and dual zone augmentation. And if you have a very big soft tissue situation, we make only dual zone augmentation. After this, I'll show you some slides. So, and that is very nice, because it's a abutment called a contour abutment. It's not from T, it's from Zimmer, but it's another big advantage from the tree systems, because the Zimmer system and the tree systems are the same. You can put on site the same abutments. So it's very easy to using a tree implant, like in this situation, putting abutment from Zimmer on the top. And then it is the big advantage of this abutment, this is contour abutment, is that you can put a crown on it, and you have to using no cement. Because you see the you can click it on the system. You can click it on the abutment. So after surgery, it's for me it's a big advantage, because I get no cementation inside the socket. No, it's easy to clean it, and the risk of infection because of cementation is you have no risk in this case. So on the right side, you see the case 1 day after implantation. Then you see the X-ray with a provisional crown. This is a 3.7 millimeter implant, 60 millimeter. And this is a case situation 1 year after implantation. And look at the shape of the bone. And this is new for me, because 10 years ago, I always using BOS in these situations. And if I'm using BOS, I will, in all cases, I'm losing bone on the buccal side. For 8 years, we're beginning to change, and for 5 years, we changed totally, because we're using no BOS anymore in this situation. I'm using BOS anymore in other situations, but not in this situation, like immediate implantation and immediate loading. And in all this situation, using human bone from the drilling hole, or human bone from manufacturers like Botus, or like Tutagen, called Purus. And you see how good is the reaction of the soft tissue, and how good is the reaction of the hard tissue. You see, if you're looking on the left side, you see no loss of the buccal bone. This on the same shapes, the same curve from the buccal bone like before. And if you're looking on the right side, you have the papillas right and left of the implant, and you have the perfect situation attached gingiva. It's perfect. And this build is 60 months after the final restoration. This is the X-ray, because the same patient came 3 years later, have to make another implantation on other parts of the jaw. And so for me, it's interesting to make an X-ray and look how fits the implants after 3 years, and look also at the buccal side. We have 2.58 millimeters of buccal bone with this kind of augmentation. So we're losing nothing. And this is for me, we lose nothing, and in my opinion, we gain a little bit bone. Not on the buccal side, but on the inside the gap, because the implant is smaller like the teeth, and so we have a bigger bone between the implant and the buccal side. And this is the reason why we are getting so much X-rays after 3 or 4 years, and we have 2 up to 4 millimeters of bone on the buccal side. But this is important. If you have 1.5 millimeters or more, then you're getting a very, very stable situation for the next 10, 20 years. And it's much more resistant against infections, because if you have a stable bone situation, you have a stable soft tissue situation, and it's not very easy for the bacteria to go inside. Here's another case. You see always the same procedure. Putting the implant. This is also, as you see on the left side, this is it's a Russian patient, 5 years old, come to us. You see the infection on the left side on the second incisor. Then we put in a small diameter implant, 3.7, to see how big is the gap. It's no problem. If you have 2 or 3 millimeter gap between the implant and the socket, it's no problem. You see after this, we're getting a very stable, big bone on the buccal side. This is very important. To see the right position of the implant, then to see the situation. The implant on the right side is an old implant, but we have to change it because it was the old abutment. In my practice, we always using hybrid abutments because we want to have abutment with the outside of zirconia. Because if you're having getting zirconia and make zirconia a little bit rough, up to 20 up to 40 microns, you're getting a much more better soft tissue stability between the soft tissue and the abutment. If you're using titanium abutments, the color of the titanium is not the same because a little bit is darker, and so is the shape of the soft tissue is not the same. And on the other side, the stability from the soft tissue and the abutment is not the same. You can check it if you're using a zirconia abutment and putting pressure. Air pressure with your air pressure inside. You see, if you're using a titanium abutment, the soft tissue will going away from the abutment. If you make the same producer with a zirconia abutment, you have not the same results because the soft tissue stays stable with the abutment. So this is for me the big advantage in the anterior region to using zirconia abutments, not whole zirconia. I call it hybrid abutments because we have the internal part of titanium, and then we put on the titanium zirconia. I'll show you it after the slides. So then you see the, on these cases, you see we're changing both abutments, and you see in the middle of the picture, you see the abutments. Inside it's titanium, outside is zirconia. These are old pictures. This case is 5 or 6 years old because for 6 years it's not possible to getting different colors of zirconia. After this, so you see some new cases. In new cases, it's no problem because it's getting not better and better because now we can have all colors of zirconia. But also in the same case, you see this white zirconia. It looks perfect. Look at the right and the left side, you see perfect soft tissue situations and perfect situation of the papilla between the implants and the teeth. So it's very easy to handle these cases after the next 10 or 20 years. This is very important to get the right position, much soft tissue, make very atraumatic extraction, atraumatic implantation, and then you're getting, if you're getting all the rules, the right connecting between the implant and the abutment, the right contact point between the crowns, and all the rules we talked before, it's no problem to get these kind of results. You see, we're losing nothing. See, so if you look on left links, we have the same height of the tissue, and this is a technique from New York University. It's very new. It's called child techniques. This is a new development. We make it like starting with this technique 1 year ago. It is very, very good to, I show you on the pictures, to make an implant with this child, and then you make a perfect provisional crown. Because with this technique, it's very easy to get in the perfect shape of the provisional crowns. I show you in the slides. This is only original slides from Professor Chu from the University of New York. This is some cases we knew before changing after tooth extraction. I told you before, if you're using, if you make an extraction of the socket and put nothing inside, this is the normal technique before, then you lose 50% of the bone. As you know, always the technique called from Daniel Busa, make an extraction, waiting 6 or 8 weeks, and then make an implantation. In all these cases, you have to make an augmentation, because if you make these techniques, you're losing bone. And there's so many examinations, egg by Schrupp or other guys. If you extracting teeth, put nothing inside, no implant or no augmentation materials, we're losing bone up to the middle of 50%. We're losing high of a bone up to 4.5 millimeters. And this is a reason for me to change my way, putting immediate implantation to stabilize the bone, stabilize the soft tissue. And if you make these new techniques I showed you before, we have not this kind of bone loss. You see on my cases, you see not so much bone loss. We're losing always a little bone with all techniques. Not possible to make an extraction losing nothing, but you're losing only a little bit. So it's most people didn't see 1 millimeter. It's not possible for the patient to see it. Here's some video. I hope your internet connection is fast enough to see the video. This video shows only how carefully we have to make extraction. You make it very carefully. No pressure on the buccal side, no pressure on the bone. On the bone. And if you make this extraction technique with you've seen in the film or see with on the slides before with a Bannock system, then we're getting a perfect shape of the soft and the hard tissue. To see the results, you see nothing. There's no damage of the soft tissue, and this is very important if you're making even implantation to make a perfect disinfection of the bone. Going inside with the sharp instruments, and then you have to de-epithelize the soft tissue because it's getting bone in this area. If you make a dual zone augmentation, it's important to make getting blood in this area, because normally you have a pocket epithelia in this area. You have to remove this epithelia to getting bone in this area, blood in this area. Okay. So it's another case. Maybe it must be the last case. This is the same. You knew to see the Bannock systems, to see how to remove the teeth, and see after this remove 2 teeth. There's nothing destroyed in the soft tissue, and the hard tissue is getting the best results. This is a type 2 socket. You see you have no bone on the buccal side, no, from the top to the apical side, and you're losing 2 bones, two teeth together. In these cases, I make a second surgery. In this case, I never want to go inside, make an implantation, and then make immediate loading, because the risk is much too high. You know, if you have losing the totally buccal side and on 2 tooth together, it's not possible to see in the future how to react the soft and the hard tissue. So in all these cases, please do not immediate implantation. This is a case how we make it. It's a technique. It's a very old technique from in the 50s, but it's a new revival by Ronald Young and for 8 years. It's called socket seal technique, just to put some soft tissue from the palatine side to the socket side. It's just a very easy technique. Remove the teeth, put some furrows or some bogus human material inside, and then to cover it with this CTGs. And there you see the results after 3 days. You see how the blood cells going inside the transplants, and to see the palatal at the donor side. This is no big harm for the patients. It's like you have to eat some hot cheese or something like this. It's the same feeling for the patient. And this is the result. And we always want to cover it with a Maryland bridge, like seen in the picture, because to getting no pressure inside the transplantates. And here you see the results. This is on the left side. You see the this build before, and this is one old case. I show it because this is the old technique we were using before with BIOS. And if I'm using BIOS in 80 up to 90% of all my cases, I'm losing the buccal side. This is the reason for me to change from using BIOS to using porous or the Botus material. Because if you're using porous, I've never have much more cases like this. It's easy because on this case we have three sides, and you can put an implant inside, make an augmentation. It's easy to handle it, but I don't want to lose so much bone. So as you see, it's put the implant in the right position, make an augmentation, and then it's very easy because with this technique, if you have BIOS inside, this is no problem to cover it, and because you have a lot of soft tissue, and it's easy to make these cases. But it's much more easier to using porous. This is a good picture to see. On the left side, you're using porous, and on the right side, you're using BIOS. To see the difference, it looks totally different. All you guys making a lot of implants, if you're using BIOS and going inside after 3 or 6 months in BIOS sites, it feels different. It feels not like normal bone. And if you have porous, you see it looks like normal bone. If you make it really inside, as you see the pictures after this, it looks like normal bone. So the last case, and then we have to stop because it's 13 o'clock. This is case gummy smile. We're losing all the front teeth. You see the X-rays before we started. It's a type 2 socket, so it's not possible to make an immediate implantation, immediate loading. So in this case, because it's a very high risk case, we make an extraction and cover it with a CTG. And after 3 months, we're going inside. Look at the picture on the right side. You see a perfect bone inside the socket. And look of the border of the bone. You see the buccal bone. And this is different from BIOS. If you're using porous, like this case, we don't destroy the buccal bone if you're using human material. It is totally different. And there you see the outcome. We make 2 implants, not 4. I told you before why. And we put an implant on the position 1.2 and 2.2, and then we make a bridge. You see, not the final result. This is just the provisional. And here you see the implants. After we put the implants, we remove the teeth in the middle, and now you see the final result. And this is a new technique. We put also porous in the big incisors, and then we make an overweight pointing, a bridge with overweight pointing design. And so you see, you're thinking that there must be 4 teeth, but there are only 2 implants. And you have a perfect shape. If you make a dual zone augmentation with a perfect shape of the crowns, it looks like you have normal 4 crowns on 4 teeth, and you see the X-ray, 2 implants, no implants in the middle, and then you get a perfect result. And you see the gap between the implant and the teeth, 3 millimeters and more. If you're using, in this case, you're using 3.3 millimeters diameter implant, then you have a lot of space between the implant and the teeth, and then I will not lose so many bone, not in the vertical side, not on the buccal side, and this is the reason for us to get a lot of bone, to have stable situations after 5 or 10 or 20 years. So that's my final case. If you have some questions, we can handle it now.
So thank you very much for this very, very great lecture with a lot of information and interesting cases. I have so far one question was from Kamis Humus. He's not online, I think, anymore, but he asked if you consider the occlusal forces. So I think it's meant to yeah.
It's an important point. If we making immediate loading, it's very important to get a little pressure inside the crown, but not the normal pressure. In my practice, I using a special folic like a rescue foil, and put it between the provisional crown and the other crowns. And if I have only a little force on the folic, it's the right forces from the for the provisional crowns.
Okay. I hope this answers the question. And then there was a question from Sun Xing Chong. He asked if you, sorry, I have to see it. He asked if you mentioned about is buccal bone loss noted while placing implants. So can we use three-sided flap elevation and place bone graft instead of semilunar flap? So he asked about the three-sided flap, flap elevation, and place bone graft instead of semilunar flap. So about the flap technique.
Okay. This is another thing, because in the last 5 up to 10 years we changed the flap design totally. The most people know the tunnel technique from Otto Suhr and from Hotzler, because we don't want to have not so much incisors in the soft tissue. You see, if in most cases you have no vertical incisors. So in all cases, I want to react in the anterior region. We don't want to have vertical incisors. It's not possible in all cases. If you have a very big bone loss and a very big infection, sometimes you have to make a ring augmentation from Giesenhagen, or you make a block augmentation. It's not possible to have no vertical incisors, but in the rest of the cases, you can do it with a tunnel technique and without using vertical incisors. So don't make vertical incisors. You can make a very big, huge augmentation in all cases without these old techniques.
Okay, and he has another question. Do you graft the jumping distance?
Yeah, I told if I have a jumping distance 1 millimeters and below, it's not necessary to make a graft, but if you have 1 millimeters and more, in all cases I make grafting. And if you see my cases, if you're using a small diameters of implant, in most cases you make a grafting, because I have 2 up to 4 millimeters of gap between the implant and the bone. So in 95% of implantation, I make a grafting.
So thank you very much. I think for now this is enough questions, because we are already a little bit over the time. Just for you all, you can always ask more questions and write them to 3D Academy. I show you the slides later where the email address is for more questions, and we're going to send them to Dr. Kamm, and he's going to answer them after the webinar. And from my side, I just wanted to say again a big thank you for this lecture. It was very interesting, and I want to inform you already for the next webinar. For example, here there is the next webinar again with Dr. Luis Bessar, which takes place on the 1st of February next year in 2017, with another interesting topic with our all-on-3 technique, which is more or less the more known technique of all-on-4. So we have there a nice interesting lecture on the 1st of February next year, 2017. And then there's another course I want to point out, and this is a master course with Dr. Marius Steigmann in Heidelberg, also in the south of Germany, very close to your praxis, and it's a very interesting course, Modular 1 course about the soft tissue management with Dr. Mario Steigmann on November 13th for 2 days. And then there is also in November on the 24th until the 26th of November, there's a 3 days course in the university in beautiful Zurich in Switzerland with Dr. Professor Christoph Hämmerle and Dr. Professor Ronald Jung in the university in Zurich. And this is a very interesting course. So if you are interested in these 2 courses, please write on info@3dental implants, and also you get all the newest information about what's happening with 3 on our Facebook site. So just make a like and get friends with us on Facebook, and you are always updated with the newest courses and what's going on with 3dental implants. And so then it's also from my side, I say thank you to everybody for listening. And as you can see here, the email address academy@3-implants.swiss. There you can ask a lot more questions to this course or to this speaking of Dr. Kamm, and I say thank you and wish you all the best until we see again in next year, I guess, with the next webinar.
Thank you very much.
Okay, thank you. Bye.